Great. Thank you very much for joining in today's session with the APSC Cloud. The session title is Sex Differences in Prevention and Treatment of Cardiovascular Diseases. The time stamp today is the 23rd of December, 12 o'clock Singapore time. And we're very appreciative again for the APSC Cloud to help us organize and plan this live session. My name is Jack from Singapore, the current president of the Asian Pacific Society of Cardiology. And let me give some preamble to this session. We know that gender differences in manifestation, progression, and outcome of cardiovascular disease is now known to be quite evident. Female patients, although have less incident coronary artery events and generally better long-term outcomes, have more morbidity and mortality when it comes to acute coronary syndrome due to sometimes ambiguous symptoms onset. Although male patients predominate in out-of-hospital cardiac arrest, worse MACE post-infarction event rates, as well as more prevalence in HFrEF patients and sudden arrhythmic cardiac deaths, female patients, however, dominate in the HFpEF realm with various etiologies. And therefore, as a community, we need to think wisely in terms of sex-specific management of cardiovascular disease that's crucial to all cardiologists. So with that, I'd like to welcome everyone to this exciting webinar that's very pertinent. Disclaimer, the content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. This content is currently made available by live stream through the APSC Cloud, APSC Facebook, as well as APSC YouTube pages. Our first speaker and my co-chair for today is Professor Khalida Soomro from Pakistan, the previous president of the Pakistan Cardiac Society, as well as chairperson of the Scientific Council of Women with Heart Diseases in Pakistan. She is an interventional cardiologist in the 7th Adventist Karachi Hospital. My second speaker of today is Dr. Chen Ying-Hwa, a professor of medicine from Taiwan, who majors in coronary interventions and structural heart diseases. She's going to speak to us on sex-specific differences post-ACS and subsequent MACE prevention. My third speaker is from Thailand, Dr. Paparapon, who's a director at the Queen Sirikat Heart Center of the Northeast. And he's going to speak to us on a slightly different track on sudden cardiac death in the young, any sex differences. After the break, my co-chair will then narrate the other three speakers. My first speaker for session 2 will be Dr. Chieh, professor of medicine from Taiwan, Taipei, who specializes in electrophysiology genetics in AF. He's going to again speak to us on sex-specific differences for sudden cardiac death prevention and treatment in adults. This will be followed by our Mongolian speaker, Dr. Gan Chimek from Mongolia National Cardiovascular Center of the Third State Central Hospital of Mongolia. She's going to speak to us on the sex-specific differences of patients with heart failure with preserved ejection fraction. Last but not least, we have Dr. George Sisong, a very respected cardiologist from the Philippines, the past president of the Philippine Heart Association and consultant cardiologist at the Makati Medical Center. He's going to finish up with the sex difference in prevention and treatment of heart failure with reduced ejection fraction. So with that, let's get started. And I would like to welcome our first speaker, who is Professor Khalida Soomro, to speak to the sex-specific differences in atherosclerotic CVD by risk factor control. So thank you, Prof. Khalida, for starting the talk. So Prof, maybe you can get unmuted first and then share your screen.
Yeah, Professor, you can start.
So I'm going to speak my presentation on the sex-specific differences in prevention and treatment of the atherosclerotic coronary artery disease by risk factor control. As we know that atherosclerotic coronary heart disease is a group of diseases which is leading killer of both women and men globally. CVD, however, now becoming more common in women than men. Results of the Framingham study suggest that there is increased incidence of coronary heart disease in men than women up to the age of 70. Increased incidence was observed in menopausal age during 40 to 45 years of age in women now. There is accumulating evidence that female-specific risk factors have influence on the impact of major risk factors and on the onset of CVD. Attention for the female-specific risk factor may enable early detection and intervention in apparently healthy women, which partially require different approaches to prevention as well as treatment and leading to differences in outcome. There is common misunderstanding of word gender and sex. Gender is socio-cultural attribute of the biological sex, whereas sex is a biological sex differentiation. It comprises sex genotype and sex phenotype. Both are XX genotype but differ in phenotype expression, thus disease, pathophysiology, manifestation, response to treatment can be related with the biological sex, whereas disease perception, use of health care, decision making, and therapeutic response can be assessed through the gender-based decisions. The data from NAN's study shows that classic risk factor for CVD in women and men are same, with the slight variation, such as incidence of hypertension is greater in women of more than 70 years of age. Diabetes is more common in women. Incidence is 8.3 versus 7.2 in men. Less than 40 HDL, which is known as good cholesterol, is more common in women than men. Smoking, sedentary lifestyle, obesity is more common in men, but the incidence varies according to the region and socio-economical conditions of the countries. The relative risk of cardiac risk factors for MI is suggested by Inter-Heart study. We all know that was a global study, and Pakistan was one of the center for that Inter-Heart study, and which showed that there was significantly associated with the increased myocardial infarction in women, 3.5 versus 2.5 than the men, with a population attributed risk of 40% in women and 25% in men. Diabetes was more commonly associated with the risk of acute myocardial infarction in women than in men. Depression was also common in the men. Although the common risk factors are the same for both sexes, with minor variation in the incidence of diabetes and hypertension and high density lipoprotein. There is significant influence of the women-specific risk factors like reproductive endocrinal disorders, pregnancy complications, and related hormones for the coronary artery disease. Recent evidence has shown the new and potentially independent cardiovascular diseases risk factors exclusive to women, such as gestational hypertension, diabetes, as well as frequently occurring endocrinal disorders in women of reproductive age, like polycystic ovary syndrome and early menopause, which are associated with the accelerated development of cardiovascular disorders with increased morbidity and mortality. Next. So we can see that there are sex-related factors which are having significant role in various stages in women's life, such as early menarche. Premenopausal women unusually have absence of the traditional cardiovascular risk factors. There is definite shift in the postmenopausal state, which is recognized as a CVD risk factor. Women with gestational diabetes, women with gestational hypertension is associated with the development of hypertension, cardiovascular disorders, hyperlipidemia, and diabetes mellitus. So these sex differences at the cellular level extend sex-specific risk factor for the coronary artery disease manifestation? Yes. According to Framingham study, there is increase in incidence of CHD during the age 40 to 70 in men more than women. We can call it that premenopause usually have low risk, whereas the age in between 40 to 65 years of age, there is low intermediate risk because of the less obstructive coronary artery disease than in the men. Coronary microvascular disease, coronary dissections, older age have definitely high risk due to the obstructive coronary artery disease. There are certain characteristics which are different in women than the men. Men are commonly develop blockages of the major heart arteries, whereas women are commonly have the diseases of small arteries, microvascular dysfunction, which can make the treatment more challenging. Yet, women have more higher rate of the myocardial ischemia and higher mortality. We can also consider the characteristics of the coronary arteries in young women also. So higher blood clot formation is there, endothelial dysfunction, small vessel size, and diffuse atherosclerosis is present in women. They are usually having less fibrotic atherosclerotic plaques, and similar magnitude of the atherosclerosis is present, but usually they have less stenosis than the men. Sex differences in the mechanism of coronary artery disease. Usually classical CAD is present in the large coronary artery in men with the atherosclerotic plaques, while in women is small dissection, dysfunction, plaque erosion, and microvascular disease is present. Apart from the small arteries, young women presenting with acute coronary syndrome show significantly less atherosclerotic burden in the epicardial vessels, coronary vasospasm involving the epicardial vessels and in the microvasculature as well. Sometimes manifest as a sudden intense vasoconstriction of an artery causing complete or partial vessel occlusion in the young women, which is different from the elderly women as well. So, coming to the benign study, we show that there is increased incidence of cardiovascular disease, including coronary heart disease, heart failure, stroke, throughout the life of the woman from age 20 to 70 years. The incidence of stroke is same in both sexes from 20 to 40 years and from the 60 to 80 years of the age, and higher in 40 to 59, but comparatively it is less in above the age of 80 years. Prevalence of coronary heart disease is equal in the age 20 to 39 and less in the other groups. So there is suboptimal, the study which was conducted for assessment of the prevalence and the risk factors, cardiovascular risk factors, treatment and control in United States from 2000 to 2016, which shows that there was a suboptimal control of hypertension, diabetes mellitus, dyslipidemia in both sexes. Statistically significant sex differences were present in trends of triglycerides level, which was which showed a reduction in mean TC was lesser in women, whereas the BMI was greater in women. Trends in treatment and control of several cardiovascular risk factors were broadly similar between two sexes. Sex difference in treatment rates might be responsible in part for the sex differences in control rate. Over here, this study was again shows that the can be highlighted. The black areas represent the treated and controlled cases. Gray areas treated but uncontrolled cases. Light gray areas untreated and uncontrolled cases. The control of hypertension, diabetes, dyslipidemia, respectively, was defined as a blood pressure was defined as a systolic and diastolic blood pressure. So control was considered when it was less than 130 by 80 millimeters of mercury. Hemoglobin, HbA1c was less than 6.5 and total cholesterol was supposed to be 240 milligram. The risk factors were current smoking, hypertension, dyslipidemia, diabetes mellitus. Over here, in the second bar, black areas represent individuals with the risk factors. Dark gray areas shows the individual with one risk factors. Gray areas were showing the two risk factors, and light gray areas showing the individual with the 3 or 4 risk factors. So this was suggestive of women of younger age tend to be having more favorable lipid profile than the men, but cholesterol level rise after the menopausal transition to level of higher than in men. The lower rate of hypertension in women than men could be attributable to the woman's stronger anti-inflammatory immune profile, which limits the increase in the blood pressure. Diabetes mellitus is a strong risk factor for the CVD in women than men due to the body size, higher BMI than men, despite of having similar levels of HbA1c. Age-specific CVD rates are lower in women than men due to the protective effect of the sex steroid hormones in women, especially estrogen. So coming towards the regional variation, sex differentiation in risk factor management also varied across the region with contrasting pattern of the treatment and lifestyle targets in Europe, Asia, and Middle East. While the prevalence of smoking was similar in between the sexes in Europe, women in Asia and Middle East were considerably having less likely to smoke than their male counterparts. Sex disparities in achievement of the treatment targets for the lipid and glucose were smaller in Europe than the Asia and the Middle East due to the less awareness and less education. Substantial differences between men and women in cardiovascular risk factor management for the secondary prevention of the coronary heart disease were less, especially in women. The prevalence of coronary heart disease is higher in men within the age stratum until 75. Due to this longer life expectancy than the male sex, women have greater prevalence of the coronary cardiovascular disease. Alarming statistics among the young women, 35 to 44 years of age, were the cause of concern. This slide shows my grandmother. She was of age 110 years when she died 7 years back. She was very hardworking woman involved in the physical work in the home. At that time, women were doing everything physically at their home. So she had a very long life. In Pakistan, in the rural areas, there is nowadays still people with a long life. So Pakistan, coming towards the Pakistan scenario, Pakistani population has one risk factor in 15.9% of the people. Women have multiple risk factors, 42 with 30% in men. Acute coronary syndrome with diabetes is 61% with 31% than the men. Hypertension 75 is 43% in men with increased risk of the coronary artery disease. Low HDL, high triglycerides in women, total cholesterol, LDL are same in both sexes. Oral tobacco use and smoking are more common in men than the women, but it is more common, announced as more common in the urban areas as well, because most of the younger generation is doing the tobacco in various forms. The prevalence of metabolic syndrome is high in women, 49% than the men, 34.8% in men, leading to the CVD in 30% of women. Physical inactivity is more common in women of the urban areas, leading to obesity, hypertension, diabetes, especially at the menopausal age. Depression is again an important cause due to the social insecurities for complications of the MI. So secondary complications are more due to the depression. Due to research and awareness regarding the coronary heart disease, there is increase in mortality because the people are aware about the heart diseases. So the incidence of heart disease is more in Pakistan, and that's why the mortality is again high since 1983 in women comparatively to men in Pakistani population. Report from the, we are coming back towards the care. Even if it is less in the high income countries, if we see global studies. So the study conducted in one of the high income countries revealed that women receive less care, investigation and treatment for the cardiovascular disease than do men, and might have higher risk of the death. However, very few studies systematically reports risk factors, use of primary and secondary prevention, medication, incidence of cardiovascular disease, death in population drawn from the community. And this is also true for the urban areas of the Pakistan. So, coming towards the guidelines based prevention and treatment of the patients. The American College of Cardiology and American Heart Association guidelines of the 2017 for the prevention and detection, evaluation and management of the hypertension in adults recommends antihypertensive medications in the presence of hypertension with threshold of systolic blood pressure more than 140 millimeters of mercury and diastolic blood pressure more than 90 millimeters of the mercury. Because of the high absolute risk of the CVD in men, more men than women with the low density lipoprotein cholesterol of 70 to 189 milligram per deciliter could be eligible for the treatment. Sex difference in the prevalence of controlled dyslipidemia in favor of men was greatest in the older age group, in which most women would also be eligible for treatment on the basis of 10 years risk of atherosclerosis, CVD of more than 7.5%. So, how can the reduction of atherosclerotic risk factor can be achieved? Exercise and physical activity in prevention of the role of exercise and physical activity in prevention and treatment of atherosclerotic cardiovascular disease. The conclusion of this study was suggestive of overall available information suggests that physical activity in range of recommended by the recent public health guidelines such as CDC, SEH guidelines has quite an acceptable risk to benefit ratio in some both the same in both sexes. In general, the effect of exercise on atherosclerotic risk factor is substantial than the achieved by the pharmacological therapy. Although the exercise significantly magnified by the other lifestyle changes such as changes in dietary composition and weight loss. The gender we can see regarding the drug therapy. The core medication for the prevention include antiplatelet agents, beta blockers, angiotensin converting enzymes inhibitor, or angiotensin receptor blockers, and statins. The efficacy of these medications for the reduction of morbidity and mortality has been demonstrated in numerous randomized controlled trials. However, evidence of such differences in efficacy, if any, are limited, especially for the older medications. Meta-analysis shows comparable benefit in both sexes. Use of AC inhibitor for improvement, survival, and reduce heart failure and MI is recommended. Thyroid diuretics in hypertensive post-menopausal female are mostly recommended. Aspirin therapy in women without any cardiovascular disease more than 65 years of age is now still recommended. The gender difference in the benefits associated with the aspirin may reflect the later onset of the CVD and relatively smaller incidence of MI in women. The greater proportion of the ischemic strokes among the women compared with the men. Gender differences in women, aspirin metabolism, and the fact that aspirin resistance is more common in the women. One of the important and controversial difference is an issue. This was the primary prevention Jupiter trial. We all know that this trial was stopped earlier than its target time because of the very excited results, and it showed that there was the 44% reduction in the primary endpoints: myocardial infarction, stroke, arterial revascularization, hospitalization for unstable angina, death caused by the CVD associated with the statin therapy. So all this reduction was found with the statin. So they are highly recommended. So coming back towards the gender differences, women are less likely to get the SE inhibitors, ARFs, lipid lowering therapy, and don't achieve the target level less than 140 by 90 millimeters of mercury. I'm talking about the Southeast Asia countries where the awareness is less. Anti-diabetics and statins. So the use of these drugs is comparatively less in women than the men. So if we are looking back towards this trial, which was conducted in 1979 to 2010, and during the 2011 to 2016, 65% of the women and 52% of the men had at least one medicine prescription for any risk factor. 16% of the women and 13% of the men used 5 or more medications. Antihypertensive and lipid-lowering agents were the commonly prescribed drugs in both sexes, and this was the result of the more awareness during this era than the previously conducted this trial period. Coming towards the important issue of whether hormonal therapy is beneficial. Indeed, the final conducted trial, which was the Danish osteoporosis prevention study in menopausal healthy women aged 45 to 50 years of women who were receiving HRT after the 10 years of their 10 years of the menopause had a significantly reduced risk of heart failure, myocardial infarction, and they had apparently decreased incidence of venous thrombosis or stroke. Keeping in view of the increased awareness during and about the cardiovascular disease in women, we can see that from the 1980s, as the coronary artery disease was known before that disease of men, but after this era, the women were thought to be having coronary artery disease. So the incidence of death was also increased in the various studies. We can see from 1980 to 2011, because the incidence studies shows more incidence of coronary artery disease in women. So definitely there is increased awareness of CVD and death in women, doubling the rate of awareness of the death, heart diseases as leading cause of the death in women during 1997 to 2012, as I have already spoke about it. The death rate resulting from the CVD decreased by nearly half due to this increasing awareness in the recent period. The HA launched its first campaign for the women in 2009, keeping in view of this. So, the conclusion of my study will be that female-specific risk factors are of influence on the impact of major risk factors, common risk factors, and on the onset of CVD leading to a worse outcome in women varied by the regions. Trends in control of the hypertension, smoking, high density lipoprotein, cholesterol, HbA1c were broadly similar but suboptimal. Reduction in TC was greater in the men. BMI was increased to a greater extent in women. Substantial differences between men and women in CVD risk factor management for the secondary prevention of coronary artery disease is present, most often to be worse for the women. Sex disparities in risk factor management differed across the regions, suggesting the need for the tailored strategies to reduce these inequalities. Said differences in treatment rates might underpin some of the differences in control rates. To improve the uptake of the guideline recommended care for the secondary prevention of coronary heart disease in both men and women, steps should be taken. Said differences in treatment rates might underpin some of the differences in control rates due to the deferred management across the region, suggesting the need for the tailored strategies to reduce these inequalities and to improve the uptake of guidelines. Recommended care for the secondary prevention and primary prevention in both men and women. So, take home message for the prevention of CVD is that classical risk factors are active in women and men, but in addition, some sex or gender specific risk factors might affect. Women have the same risk as men that are the 15 years younger. Women are still untreated. Thank you so much for patience with
Thanks, Prof. Khalida. That's really a tour de force lecture. I think it really covered a lot of ground. Can I ask you to stop share for the time being, the slide deck? So I think we used up quite a lot of time. I just like to move on to two quick questions and comments. One for Dr. Chieh from Taiwan. Dr. Chen, may I ask, looking at Prof. Khalida's slide deck, what is your comment on the ideal, or is there any differences in terms of investigations between men and women to detect underlying CAD? What do you think are some of the caveats against, for example, a treadmill test for women versus men? Is there any differences? Dr. Chen?
Uh, could you hear me?
Yes, you're quite clear. Please go ahead.
From previous study, it seems like treadmill, if women receive treadmill test, will reveal more false positive in women. So I think CT angio or presenting saline are more reasonable for detection of CAD in women.
Any age cutoff, because both involve some form of radiation? Is there any guidance to the age before you recommend this test to women?
You mean if female is pregnant, so you think
No,
CT is not?
Younger ladies, less than 40, we recommend it as a first cut investigation, CT.
Because treadmill is less expensive, so the first line should be a treadmill test. But if it's equivocal or inconclusive, I will proceed with percent saline or CT angio.
Thank you. Dr. Ganchimek, can I just ask also what's the observation in Mongolia? Prof. Khalida presented quite well that there's two bimodal presentation. When women do get coronary artery disease when they're much younger, the mortality rate is actually quite significant. And most times related to cardiometabolic, diabetes, smoking subsets. Do you have this observation in Mongolia as well? Is there a younger subset of women getting coronary artery disease? Dr. Ganchimek?
Thank you. Can you hear me?
Yeah, go ahead.
So we, unfortunately, I think we don't have enough data on this. Yeah. The majority of the patients who hospitalized because of the coronary artery disease are, majority of them are old male patients. Yeah, so it's very rare in our condition.
That's great, because in Southeast Asia, increasingly we're getting more younger ladies with risk factors, especially smoking and diabetes, presenting with AMI. And it's actually quite distressing to treat young ladies with significant CAD. So I think in the interest of time, we'll move on to the second lecture by Professor Chen Ying-Hwa, who's going to speak to us on sex-specific differences when it comes to ACS? And what is the treatment and intervention strategies to reduce event rates? Professor Chen, please.
Good afternoon, everyone. Could you see my slide?
Not quite yet. So still waiting to see your slides.
Yes.
Perhaps.
So, could you see my slide?
I'm so sorry, not yet.
Oh. And
there's some echo. I think you have two systems on.
so, could you see our slide, my slide?
I'm so sorry, still no. And I think there's some echo in your two system. So if there's some technical difficulties, perhaps I can let you take some time to sort it out. I'll move on to Paparapon first from Thailand to share his talk on sudden cardiac death in the young. Dr. Paparapon, please.
Okay.
Thank you.
Okay, you see my screen?
Yes, yes, please go ahead.
Okay. Okay. Thank you for inviting me to join this interesting conference. Today, my topics is to talking about prevention and treatment of sudden cardiac death in the young and sex difference. Background for sudden cardiac death. Everybody know that sudden cardiac death is a death from definite or probable cardiac cause within 1 hour of symptom onset. And the incident from international study show that in the patients who is aging under 35, the incidence rate is around 3 per 100,000 person years. And when we're looking into the cause of sudden cardiac death, when we're looking into the patients under 35 years old, the most common cause is consisting of the cardiomyopathy, congenital heart disease, or sometimes the patient from the ion channel disorder. And another thing that we have to thinking of is anomalous coronary artery and myocarditis. And the point that I want to make today is how important of the sex difference in cellular electrophysiology and surface ECG. When you're looking into the electrophysiology of the heart, you will know that the premenopause adult women have faster baseline heart rate. The premenopause adult women have longer QT interval and has increased ventricular repolarization heterogeneity when compared with the men on the similar age. And the women have a larger spatial difference between QRS and T-wave loop orientation. And the sex hormone influence calcium current in the heart. And the female heart have reduced expression of the HERG. And the HERG is the common mutation we see in the long QT2. And the estradiol can inhibit IKR. And the testosterone exhibit protective arrhythmia influenced by testosterone increasing the activity of IKS. I think this is the electrophysiology of the heart and the surface ECG that the sex or the hormone cause the difference in the male and female. And I think in terms of sex difference effects, sudden cardiac death in the young, I think in these 2 years, we have very great review article from the American Heart and from the European Society of Cardiology. And I think in terms of primary electrical disorder, we have the sex difference in three common diseases like long QT syndrome, Brugada syndrome, and catecholaminergic polymorphic VT. In terms of structural disorder, the sex difference may be pale in hypertrophic cardiomyopathy and arrhythmogenic RV cardiomyopathy. So, come to the first case, 22 years old male presented with cardiac arrest during playing football. When we work up, echocardiogram is normal. When you're looking into the author, you see this in the upper panel, you see the torsade poor, and when you're looking into the lower panel, you will see the ECG show the QT prolonged, and you see the T-wave alternate. So when you see the T-wave alternate from the ECG and the QT prolonged, and make the patient have torsade poor, you have to thinking of this syndrome we call the long QT syndrome. When you're looking into how to diagnose long QT syndrome, this is from the European guideline. You can diagnose long QT syndrome with a QTC more than 480 milliseconds in repeated 12-lead ECG, or you have the long QT list score more than 3. And sometimes long QT may diagnose in the presence of the confirmed pathologic mutation, irrespective of QT duration. So this is important because the long QT is a disease that can diagnose by the mutation of the gene. Because when we're looking into the gene-specific trigger for the type of long QT, you have to know that the long QT1 may stimulate by the activity by exercise or swimming or the playing sport. For the long QT2, the stimulation or trigger of arrhythmia may be from the auditory trigger. And for the long QT3, the events may trigger when you have the high vagal tone, like you have the event occur during the night or when you sleep. And for the ECG pattern, we have suggestion from the ECG pattern that you can make diagnosis of the type of long QT. Because the long QT1, you have the whiteboard base of the QT. Long QT2, maybe you have the bifid T wave, and long QT3, you have state of the ST segment and the normal looking T wave. And this is the long QT list score. If you have the score more than 4 points, this is a high probability of the long QT syndrome. So, sex difference in long QT syndrome, this is maybe explained by the hormone effect on the ion channel that have defect by the genetic mutation. Usually, if we're looking into the normal QT interval, physiologically, the women have the longer QTC than men. And in terms of the sex difference, if you're looking into the incident in the young, the boys with long QT1 from the KCNQ1 gene mutation have higher risk of ventricular arrhythmia and fatal event than girls. But the 10 switch into puberty, when the age go to the puberty, the risk of event in male have lower, but the female have higher risk after you go into the puberty. Therefore, if there have been no event until the age of 16, the risk of ventricular arrhythmia in male decrease, while female, the risk is still the same or increase when you go into the puberty. And from some specific type of long QT2, from the KCNH2 gene mutation, this is the high risk of arrhythmia in post-pubertal female and remain increased both during childhood and adulthood. This is why sex is important when you managing long QT syndrome. Especially when you're looking in the long QT syndrome, because when you're looking into the ECG will show the bifid or notch or low amplitude T wave. And this is the point you have to make important thing when you manage of the long QT2 patient. Because long QT2 women who have the QTC more than 500 milliseconds are high risk, and the risk will continue after menopause. So lifelong follow-up and continue long-term therapy, like you have to continue beta blocker lifelong. And another thing, long QT2 women, the risk may be increased postpartum period, including first 9 to 12 months after delivery. So in terms of management, in the woman, beta blocker therapy should be continued during pregnancy and postpartum in all long QT women, especially in long QT2. And the sex difference in long QT syndrome should be considered in risk stratification for ventricular arrhythmia, especially high risk of arrhythmia, even in pre-pubertal or childhood in boys and the women after puberty. This is the point of the long QT and the sex difference. After this, the competitive sport have to avoid both male and female, avoid QTP prolonging ducts, avoid hypoK both men and women. In terms of management, if you have cardiac arrest for long QT, you have to put the ICD. And the medication of choice for long QT syndrome, all men and women are beta blocker. Another disease, if you have to see in the Asian a lot, this is a 32 years old male presented with cardiac arrest, and this is the ECG after ROSC. You see in this ECG, when you're looking into the V1 and V2, you have diagnosis of the COV type or Taiwan Bukada ECG pattern in V1 and V2. So this is we call the Bukada syndrome. We know this disease from 1992. This is the first ECG report from the Bukada group from the Professor Joseph Bukada and Petro Bukada. So now we know that Bukada syndrome have diagnosed by ST segment elevation COV type in the right precordial leads. They have spontaneous or sometimes have to provoke by high intercostal space ECG, or you have to use that like the sodium channel blocker to provocative the surface EKG Bukada type 1. The study date in patient with structural normal heart had a result for Bukada syndrome cause VF, and you're looking into the incidence. Male Bukada syndrome more common, age harm more frequent in female. The mean age is around 40. The prevalence is around 1.4% in Japan, 1.8% in Japan, and only 0.4% allow this in European and USA. The sex difference in Bukada syndrome, we see a lot in male patient, and the male patient have the greater symptoms and greater more event rate and more frequent spontaneous type 1 in post-pubertal male patients. Why predominance of Bukada syndrome in male? We have to listen. First, androgen may affect ITO channel, transient outward potassium channel, and may aggravate ion channel dysfunction. Another reason, we think that the transient outward potassium channel or ITO density was significant greater in male compared with female when we look into the ITO density in the RV epicardia. So this is how you diagnose Bukada syndrome. You can do by sodium channel blocker, duct challenge test, or sometimes you just put the ECG, we call the high intercostal lead. These two methods can uncover Bukada syndrome ECG type 1. So you can diagnose Bukada syndrome by spontaneous type 1 ECG or provocative by using ducts or high intercostal lead ECG. So in terms of management and prevention of the sudden death in Bukada syndrome, you have to know that the effect of the high glycemic index diet. This is my paper. For the last 10 years, we see effect of high glycemic index diet can cause ST segment elevation in Bukada syndrome. And another thing, you have to looking and take care of the patient who have Bukada syndrome because the effect of temperature. When you have fever, you have high temperature, this can trigger arrhythmic event in Bukada syndrome. So the recommendation when you manage the Bukada syndrome, you have to do three things. First, avoid duct that may induce ST segment elevation in the right precordial leads, like the duct that can block sodium channel, like amitriptyline, like sodium channel blocker. The second thing, you have to avoid excessive alcohol intake and large meal, because we have to know that high glycemic index diets after you take alcohol or large meal can cause hypoK and sometimes can cause the ECG Bukada syndrome SC elevation and cause phase 2 re-entry and cause VF. If you have the fever can trigger arrhythmic event in Bukada syndrome. You have to prompt treatment of any fever with antipyretic drugs in Bukada syndrome. This is the thing you have to advise to all the Buccal syndrome patients. So in terms of treatment, no difference between treatment between Buccal syndrome male and female. If you have cardiac arrest or you have the sustained VT, you have to push the ICD. And if you have the recurrent episode of the ICD shock, you may give the medication like quinidine to treat the recurrent ICD shock for appropriate therapy. In terms of Buccal VT-VF storm, you can use isoproterenol infusion to treat the VT storm from Buccal syndrome. Another topic, I think this is the question we've seen a lot when you take care of the Buccal syndrome. The Buccal syndrome who have cardiac arrest post-ICD can exercise or not? The answer is yes. If post-ICD more than 3 months, they have no arrhythmic event after you push the ICD. You can interrogate the ICD, no arrhythmia, no VT, no VF. And after that, you can share decision making with the patients how they can exercise. But you have to know that exercise can precipitate cough type during recovery phase of exercise. And if the Buccal syndrome patient want to participate in sport or exercise, they can exercise, but we don't recommend to play the competitive sport. They just do only the moderate sport intensity that not associated with increase in core temperature more than 39 degrees Celsius. We know that if the temperature in the body has high temperature, they can cause Buccal syndrome trigger to VT-VF. And have to advise, you have to do the Buccal syndrome patient do not to do endurance exercise under extremely hot weather or the humid condition. This is the advice thing that you have to advise to the Buccal syndrome patients. This is another case we can see in the sudden cardiac death in the young. This is my patient, 16 years old male, present with cardiac arrest during playing football. If you're looking into this ECG, you will see the beauty of this ECG. You have bidirectional ventricular tachycardia. So this is we call the ECG is bidirectional ventricular tachycardia. After that, the baseline ECG have normal, no QT prolongation, the normal ECG as baseline. So when we push this patient to do the exercise state test, you see from the state test, you can reproduce bidirectional VT. So this is diagnosis of the catecholaminergic induced polymorphic VT. This is the autosomal dominant and the genetic heterogeneous. This disease may be occur during exercise or state emotion. It can start at young age. The point that the baseline ECG must be normal. Now we know that the catecholamine-induced polymorphic VT, or we call the CPVT, have the defect of the lyanodine receptor. This is a defect, and you cause the calcium leakage of calcium in the cell and trigger calcium leakage from sarcoplasmic reticulum. So in your cell, you have like the delay after depolarization, trigger calcium overload to cause the bidirectional VT. So in CPVT, the term of sex difference, because we know that young men with the RYR2 mutations or lyanodine receptor mutation were shown to have higher risk of cardiac event than women, and men are more likely to be positive when you're testing for the lyanodine receptor mutation. In terms of treatment, I think the treatment is the same between male and female CPVT patient. You have to treat patient with beta blocker. Sometimes if beta blocker could not control the symptom, you can add fecamide, because fecamide can block the sodium calcium exchanger channel and can block the channel that have the mutation. So this can treat the CPVT. The ICD implantation preserve only the patient have sudden cardiac death. Another patient, when you see this ECG, these are male 25 years with cardiac arrest during playing football too. When you're looking into the ECG after the ROSC, you see the patient have the left axis deviation in the young male. So this patient with we suspect of the LVH, you see we have the big septal force and big septal Q wave. When you have the young male cardiac arrest, LV hypertrophy, big septal force, big septal Q wave, you have to thinking of about the hypertrophic obstructive cardiomyopathy as the cause of sudden cardiac death. Hypertrophic cardiomyopathy, most common cause of sudden cardiac death in the young, and the sudden cardiac death is primarily related to VT or VF. This is autosomal dominant inherited disease, and the important is the penitence is higher in men with the ratio of 3 to 2 ratio compared with women. And the prevalence we see in sudden cardiac death list is around 1% per year. We see hypertrophic cardiomyopathy male in men more than women, but the sudden cardiac risk is the same. So sex should not be considered in risk stratification for ventricular arrhythmia. This is the genetic responsible for hypertrophic cardiomyopathy. Is from the mutation of beta myosin heavy chain, myosin binding protein C, or mutation in cardiac troponin T. Like I tell you, penitence in this disease is higher in men with 3 to 2 ratio compared with women. And this is how to diagnose hypertrophic cardiomyopathy. You can diagnose by doing the echocardiogram. Sometimes you do advanced imaging like cardiac MRI. This can diagnosis of the hypertrophic cardiomyopathy. This is another patient, Thai male, 18 years old, present with chest pain and cardiac arrest. This ECG is surveillance of the VF. And EKG after cardiac arrest, you see you have the LV hypertrophy. You have a lot of voltage in lateral lead. You have deep inverted T in V4 to V6. So this ECG pattern we call the Yamaguchi ECG pattern. We call this ECG pattern we can see in apical hypertrophic cardiomyopathy. And in this case, we go to do the cardiac MRI and we can diagnose apical hypertrophic cardiomyopathy. And in terms of treatment, like I tell you, you put the ICD in the hypertrophic cardiomyopathy patients who have previous event like sudden cardiac death, VF, or sustained VT. And for risk stratification, we use a family history of sudden cardiac death. We use massive LV hypertrophy. We use apical aneurysm. We use EF less than 50%. But like I tell you, this disease is common in male than female. But the sex, not the risk factor for the ventricular arrhythmia. This is another case. 30 years old male, start post CPR defibrillation. You see the ECG. You have positive in AVR. You have negative concordance from V1 to V6. You have AV dissociation. So in this patient, this is a VT. And the VT have the left bundle band box morphology VT. So this is from the RV origin. So we have the RV origin VT in the young. We have to thinking of the RV cardiomyopathy. And this is the ECG after cardioversion. Everybody see, this is we call the epsilon wave. So this is epsilon wave, the X-ray show cardiomegaly. So this disease, we thinking of the arrhythmogenic RV dysplasia. So we looking into the echo, you see the dilate right ventricle and non-poor coaptation of the tricuspid valve. We go to do the cardiac MRI, you can see accordion sign in RV. So this is we can diagnose arrhythmogenic RV dysplasia. Arrhythmogenic RV dysplasia or arrhythmogenic RV cardiomyopathy. This is from the myocardial loss, and then adipose tissue and fibers have to go infiltrate replacement of the RV at the RV free wall, subtricuspid valve, and sometimes the alveolar tract free wall. This is the second common cause of sudden cardiac death in sacral heart disease. And this is caused from the genetic mutation from the desmosome gene. This can cause the reentrant VT with RV origin because you have some scar from the fibrofatty infiltrate. In terms of sex difference, higher disease penetrant in men 3 times when compared with women. And different from the hypertrophic cardiomyopathy because the male sex has been reported as the risk factor for ventricular arrhythmia. And regular exercise had associated with the high arrhythmic event. So this disease we have to stick and tell patient you don't go to playing the competitive sport because this can cause the RV progressive dysfunction and can cause higher arrhythmic event. How you diagnose the ARVC? You can use 2019 Heart Rhythm Society consensus. You have to have the VT from the right ventricle that can present have the right bundle band block VT. You have major epsilon wave and you can diagnose by the MRI. So if you have the two major criteria, one major criteria plus two minor criteria or four minor criteria, you can diagnose ARVD or ARVC. So in terms of therapy, ICD used to put in the ARVD patient who have history of sudden cardiac death or who have history of sustained VT. So in management of ARVC, you have to do these four things. You have to do the accurate diagnosis. You have to do the less certified for sudden cardiac death. Now we have the online calculator that can calculate the list of sudden cardiac death in ARVD, and you can justify in high risk group to do the primary prevention for ICD. You have to minimize symptoms and ICD shock. You can give beta blocker, amiodarone, sotalol, or sometimes you give, if the patient could not control VT, you can go to do the RF ablation for VT. In terms of prevention of the progression of the disease, you have to tell the patient stop competitive sport. You have to take beta blocker, take AC inhibitor in severe disease. So I think this is a pose in treatment and prevention for hypertrophic cardiomyopathy and ARVC. For the ICD in hypertrophic cardiomyopathy, for survival of cardiac arrest or sustained VT, this is for the secondary prevention ICD. For primary prevention, the risk factor for sudden death is family history of sudden cardiac death in first degree relative, or the maximum wall thickness more than 30 millimeters, unexplained syncope or non-sustained VT. But like I tell you, sex should not be considered in risk stratification for ventricular arrhythmia in hypertrophic cardiomyopathy. For arrhythmogenic ventricular cardiomyopathy, male sex have reported as a risk factor for ventricular arrhythmia. This is a sex different have payload in ARVC. So in conclusion, I have to answer the question for the topic that you give to me. For sudden cardiac death in the young, any sex difference? I think for cardiac ischemia cause of the sudden death in the young, maybe from the malignant type of coronary anomaly, no sex difference for the anomalous coronary artery. But for the cardiomyopathy, hypertrophic cardiomyopathy, you have the male predominate for prenatal of disease, but risk of ventricular arrhythmia same for male and female. For arrhythmogenic cardiomyopathy, male predominate and male can increase risk of ventricular arrhythmia. For the long QT syndrome, for the boy in the children boy increase risk of ventricular arrhythmia. But after going into the puberty, the risk increase in women, especially in high risk for women in long QT2, extended to the postpartum period. For Bucada syndrome, very male predominate 5 times more than female, and the risk this comes from the ITO, with more frequent in male, and male have higher risk of ventricular arrhythmia. For the CPVT, we have seen male predominate with higher risk of ventricular arrhythmia. Thank you for your attention. If you have any questions, you can ask me. Thank you.
Thanks, Dr. Paparapon. Excellent lecture again. Really a comprehensive review of sudden cardiac death causes in the young, differentiated between gender. So I learned that everything is more common in males except for long QT, probably. Can I ask one question? In Thailand, then, in athlete pre-participation screening, does Thailand screen with ECG or just history physical examination? Or is there any screening warranted in athletes?
Okay, very great question. Because usually we take a history and physical examination, but because for sudden death in the young, it's a very disaster event when you see the athlete die in the competitive sport. So in Thailand, we usually do 12-lead ECG when we screening for the athlete. or the competitive sport in school sport, we always screen the ECG.
Is there a difference between playing golf versus playing Muay Thai as a sport?
We only do ECG when you do the high intensity sport. For the moderate intensity like golf, we don't screen for the ECG. But if you want to participate in high intensity sport or competitive sport, we used to screen the ECG because we want to detect some disease and make commentation like hypertrophic cardiomyopathy, long QT syndrome, Bucada syndrome, or some disease that we have to advise or make some advice. You have to take more banana when you playing tennis because if hypo-K, maybe some trigger for arrhythmic event.
Thanks. I think most people classify golf as low intensity.
Yeah.
But Muay Thai definitely high intensity. So thank you very much. Have you stopped the screen share? We'll move back to Professor Chen Ying-Hwa for her talk on ACS management for gender differences. Professor Chen, please. You're muted, Professor Chen. Do you mind if you unmute yourself?
Yeah, do you see my slide?
Yes, please go ahead. Can you go to full screen?
Okay.
Okay, that's great.
Good afternoon, everyone. I'm Professor Ying-Hwa Chen from Taipei Veteran General Hospital. I'm delighted to talk about 6 specific differences in the treatment of acute coronary syndrome, intervention, and subsequent MACE prevention. I will divide my talk into 3 parts. First, is there a stats gap in the management and outcomes in patients with ACS? Second, now atherosclerotic mechanism or ACS in women, such as spontaneous coronary dissection, Takotsubo cardiomyopathy, and Minoka. Third, and I will discuss how to close the gap in sex disparity in ACS. You can see for traditional risk factors such as hypertension, diabetes, and smoking are more prevalent and have greater clinical impact in women compared with men. Additionally, there are several non-traditional cardio risk factors unique to women, including SLE, gestational diabetes, hypertension in pregnancy, and depression. Women tend to present more often with atypical symptoms. The most common symptom of a heart attack for both men and women is chest pain, but women may experience atypical symptoms such as fainting, indigestion, and extreme fatigue. You can see from the right panel, young women tend to present less likely with chest pain, and women presenting without chest pain have greater mortality. Although deaths from cardiovascular disease have decreased over the past 3 decades, women in many parts of the world still have worse outcomes after acute coronary syndrome. The same findings were observed in our country. You can see over these years, the incidence of AMI were constant in both men and women, but in hospital mortality rate were constantly higher in female, and there was no significant improvement of mortality, both in STEMI and non-STEMI for female patients over these years. From Taiwan ACS force its prospect. There were more than 338 centers in Taiwan. 24 patients were women, older, and have more prevalence of hypertension and diabetes. And women were more commonly present with non-STEMI and non-obstructive coronary artery disease. The in-hospital outcome, including all-cause deaths, cardiovascular deaths, new onset heart failure, and atrial fibrillation, were higher in women. And followed to 1 year, you can see the all-cause mortality was almost twice as high as men. If we focus on STEMI patient undergoing prime PCI, you can see women less often underwent prime PCI, and the door to balloon time was longer for women patients. And in hospital and 1 year mortality rate were higher in women. There were two ACS registry in Taiwan. You can see women has longer onset to door time. It means women delay seeking medical care. It's about 13 minutes delay of women seeking medical care compared with men. Gradually, between these two registries, decrease in door-to balloon time, and there are higher percentage of door-to balloon time, less than 90 minutes, were achieved in women. A recent publication investigates more than 70,000 AMI patients in Canada. We can see their findings were similar. Women has non-obstructive coronary artery disease and less often receive revascularization. After adjustment, women with STEMI compared with men were at higher risk of death at 1 year and even 5 years after discharge, and the development of heart failure either in hospital and at 5 years after discharge remain higher for women. Yang-MI registry is the largest study to examine difference between young men and men presenting with first MI under 50 years of age. You can see women are more likely to have diabetes and underlying rheumatology risk factor. And women were more likely to have atypical symptoms such as dyspnea, palpitation, and fatigue. In addition, women were less likely to undergo angiography and revascularization, and less likely to be on guideline-directed post-MI medication. You can see the cause angiography finding 6% of patients have spontaneous coronary artery dissection, and 10% of patients, women, has non-obstructive coronary artery disease. Followed to 11 years, all-cause mortality were still higher for women. Previous studies show women undergoing PCI for ACS have high risk of vascular as a side complication. According to rival trial, female was a significant predictor of major vascular complication. You can see the hazard ratio of female is 2.4, And if we use radio access, the decrease in major vascular complication is greater for women than for men. The absolute risk reduction was 3% for women and 2% for men. Likewise, metric access trials show men has a low risk of exercise bleeding, and the benefit with transradial access was relatively greater in women. Next, I will discuss some non-obstructive coronary artery disease such as spontaneous coronary artery dissection, Takotsubo syndrome, and Minoka. First, spontaneous coronary artery dissection, SCAD. It's defined as non-traumatic, non-iatrogenic, non-atherosclerotic separation of coronary artery wall by intramural hemorrhage, creating a false lumen. We should consider a diagnosis of spontaneous coronary artery dissection in the following clinical setting, such as MI in young women and absence of typical cardiovascular risk factor, especially if patient in peripartum state and patient have a history of fibromuscular dysplasia and experience extreme emotional or physical stress. SCAD is the underlying cause of 2 to 4% of ACS and account for 0.5% of sudden cardiac deaths, occur most commonly in women, especially in young women under 60 years of age. SCAD account for about 1/3 of ACS presentation. The most common precipitating factor was emotional stress. SCAD has 3 types. You can see figure A is Taiwan. It's the most classic SCAD. There is multiple radiolucent lumen or arterial wall contrast staining. Figure B is type 2 SCAD. It's often missed without a high index of suspicion. You can see diffuse stenosis that cause varied severity and length. It comprises 70% of SCAD. And figure C show type 3 SCAD. It's mimic atherosclerosis, only have focal or tubular stenosis, usually less than 2 centimeters. In addition to angiography, IVUS and OCT are the gold standard for diagnosis of SCAD. SCAD is not a real cause of ACS, predominant in women, but is still under diagnosis. Among patients with SCAD, the mean age was 46 years and 94% of patients were female. The most common presentation was STEMI, and cardiogenic shock or cardiac arrest was observed in 16%. Most of patients can be treated with conservative treatment because coronary revascularization is associated with increased risk of complication and adverse outcomes. Only patients with Lang-Mann disease or severe proximal two vessel dissection have hemodynamic instability and ongoing ischemia symptoms. Those patients we may consider PCI or CABG. Next, I will discuss Takotsubo syndrome. According to Mayo Clinical criteria, the diagnosis of Takotsubo syndrome requires the presence of all four of the following. First, transient dyskinesia or mid-ventricular segment. Second, absence of obstructive coronary artery disease. Third, there are new EKG abnormality or troponin elevation. Fourth, there's absence of pheochromocytoma and myocarditis. Takotsubo syndrome represents 1 to 3% of all patients and 5 to 6% of female patients presenting with STEMI. Typical patients were post-menopause women after an emotional or physical stress event. Women has an almost 9 times higher risk compared with men. You can see from the right panel, a patient present with STEMI, everyone should underwent emergent coronary angio. A patient with non-STEMI, you can calculate Intertech score, including female sex, emotional stress, physical stress, non-STEMI, psychological or neurological disorder, and QT prolongation. If Intertech score is more than 70, indicate high probability of Takotsubo syndrome. And if you suspect patient has Takotsubo syndrome, you can arrange transthoracic echo. If apical blooming is present, then we should arrange CT to investigate if there is any coronary artery disease. If CT is negative, we can skip coronary angio. If patient have unstable hemodynamic or arrhythmia, we can proceed to do coronary angio to rule out MI. Takotsubo syndrome is not benign, although it's a reversible condition, but heart failure and variable arrhythmia can occur during the acute stage. So 1/5 of in hospital patient, 1/5 of patient may experience heart failure or mitral regurgitation or even cardiogenic shock during admission. Parameter predicting adverse in-hospital outcome include physical trigger, acute neurological or psychological disease, and initial troponin elevation more than 10 times or upper reference limit, and admission LVEF less than 45%, and male patient has a worse outcome than female. The long-term mortality of patients with Takotsubo syndrome is similar to patients with CAD at 5 years, and death rate estimate to be 6%, and rate of MACE and cerebral vascular event was about 10% per patient year, suggesting Takotsubo syndrome is not a benign disease. Next, we will discuss MINOCARD. MINOCARD is myocardial infarction in the absence of obstructive coronary artery disease. It's defined as a patient with MI and have less than 50% of stenosis or of epicardial artery. It occurs in 6 to 15% of MI, most commonly affect women. And it's also, it's not a benign disease. The 4-year rate of MACE is 24%, and 5-year mortality rate was 11%. HAP study was recently presented in AHA. The study identified 170 female patient diagnosis with MINOCA, and the correlation was identified by OCT in 46%. The cause may be plaque rupture or intraplaque cavity or layered plaque. There was 74% of patients have abnormal cardio MRI. When we combine OCT and cardiac MRI finding, the cause of MINOCA was identified in 85% of patients. 2/3 of patients were ischemia origin, and 21% were non-ischemia origin, such as myocarditis, Takotsubo syndrome, and dilated or hypertrophic cardiomyopathy. The cause of MINOCA include plaque fissuring or erosion, microvascular or epicardial spasm, myocarditis, Takotsubo syndrome, and coronary embolization. The treatment of MINOCA should be based on the underlying cause. In occlusion, women with ACS have higher in-hospital 1 year and even midterm mortality due to older age and a higher clustering of cardiovascular risk factor. Women were delayed in reperfusion. They experienced a 30 minutes pre-hospital delay from symptom onset to hospital presentation. So total balloon time was longer. And women receive low use of reperfusion therapy and secondary prevention, such as DAP, beta blocker, ACI, and statin. And female patients experience high prevalence of heart failure at admission and after discharge, and they experience more bleeding complication after intervention. Such complication could be significantly reduced by radial access. But when we adjust clinical characteristic and treatment, the sex difference in hospital mortality was no longer observed in female patients. We should close the gap in sex disparity in ACS. First, we can identify sex-specific risk factors such as SLE, diabetes, some rheumatological risk factor to improve females' risk stratification. And because female patients present more with atypical symptoms, so we should increase awareness of ischemic heart disease and use sex-specific guidelines and adequate inclusion of women in clinical trial. And we should use more diagnosis images to evaluate ischemic heart disease in women, such as CT for epicardial stenosis, PET and MRI for microvascular disease, IVUS or OCT, to investigate those non-atherosclerotic mechanism of ACS. Thank you for your attention.
Thank you, Professor Chen. Again, excellent comprehensive lecture, and I learned that for the rarer causes of AMI, now instead, unlike sudden cardiac death, is more common in women, whether it's SCAD, menopausal stress, cardiomyopathy. So there's a question from Professor Lin and his team. I saw that in women, the onset of CAD AMI is at least a decade older than males. So it's a persistently higher morbidity and mortality rate of women with AMI due to the age-related worse coronary anatomy, or is it due to delay in treatment and getting evidence-based treatment, which is more likely the cause for the increased mortality in women?
From many studies, women always receive less often invasive treatment and medication after discharge. And many studies demonstrate if we adjust this risk factor, the outcome of women and men were almost the same. So the most important factor for worse outcome for female patient, I think it's delayed diagnosis, delayed presentation, and under treatment.
Okay, thank you for that. Why do you think there's more atypical presentation of AMI in women as well? Why are the symptoms atypical?
You can see this slide.
You're sharing a slide? Yep.
Yep. You can see the most common symptom of heart attack for both men and women is still chest pain, but women experience more fainting, indigestion, and extreme fatigue, especially in young women less than 45 years old. A typical symptom was the more prevalent presentation.
So I think the take-home message is that I think in the ladies, we have to have a higher index of suspicion so as not to miss AMI diagnosis, and that will directly impact their mortality rates. So thank you for that, Professor Chen. In the interest of time, we'll move on to the next lecture by Dr. C on Professor Chieh on the prevention and treatment of sudden cardiac death in adults, whether there's any gender differences.
Hey, 好了，哎，好吧，我去看。
Are you muted? Maybe you can. You're good. You're good. Thank you.
Good afternoon. So I'm Chieh from the National Taiwan University Hospital. So now I want to talk about is there any gender difference in the prevention and the treatment of sudden cardiac death in adults? And actually, in my talk, there is a lot of overlap with the previous talk by Dr. Moran, because the pattern of gender difference in hereditary sudden cardiac death are very similar in young patient and adult patient. So we first look at the definition of sudden cardiac death. I think this is very simple. every cardiologist know what sudden cardiac death is, but it is the most catastrophic presentation of any cardiovascular disease. So it's the most important issue we deal with in our clinical practice. So the common causes of sudden cardiac death, I think the number one cause is ischemic heart disease in adults. And the second most common cause is cardiomyopathy. And other rare causes are hereditary channelopathy, such as long QT, short QT, Brugada syndrome. And some have valvular heart disease. In the most rare condition, the patient may have congenital heart disease, and most of them have congenital abnormality in aorta, such as a bicuspid aortic valve or Marfan syndrome. So what about the incidence of sudden cardiac death? And in general, the incidence or prevalence of sudden cardiac death is higher in Caucasian than in Asian. So what's the actual gender difference in adult sudden cardiac death? When we talk about sudden cardiac death in adult patient, I think because the number one reason of sudden cardiac death is the ischemic heart disease. And the man itself is a risk factor for ischemic heart disease. So it is very logical to think that men have a higher incidence and the prevalence of sudden cardiac death than women in the adult population. But as the previous talk given by Professor Chen, although men may have a higher incidence or prevalence of sudden cardiac death, but the prognosis may be better in men because, as the Professor Chen say, the prognosis and survival is worse in women patients with acute coronary syndrome or myocardial infarction. And all these conditions are the number one cause of sudden cardiac death in the adult population. So now we look at the specific disease entity that cause sudden cardiac death in adult population. I think as I told, the gender difference in all these disease entities are very similar in young and adult patients. The only exception is the long QT syndrome. So now we look at the specific disease entity now. So we first look at the cardiomyopathy in adult patient. For those adult patients with hypertrophic cardiomyopathy, the female patient is likely to have outflow tract obstruction and have worse symptoms. And according to a large survey in 2005 in Caucasian population, actually the female patient with hypertrophic cardiomyopathy have worse prognosis and higher incidence of sudden cardiac death. And this is different from the information given by Dr. Paraloman in our previous talk. Maybe we can discuss this later. But through my review, the prognosis of hypertrophic cardiomyopathy is worse in women patients. And for the disease of dilated cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy, the male patient are associated with severe symptoms and manifestation, and also have a worse outcome. And the prevalence and the incidence of dilated cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy are also higher in adult men. And regarding Takotsubo cardiomyopathy, I think Professor Chen talked a lot about this cardiomyopathy. Is much more common in the women population, and the prognosis is also worse in the women population. So now we look at the so-called channelopathy. We first look at short QT syndrome. That is not very common in our Asia Pacific region. And all this data was gathered from the Caucasian population. And in general, for the male patient with short QT syndrome, male patients tend to present with syncope. And there is no gender difference in the initial presentation of sudden cardiac death. But in the long-term follow-up, after they received the ICD implantation, the women patient tended to have a higher probability of cardiac event, either ventricular tachycardia or ventricular fibrillation or sudden cardiac death during follow-up. And the female patient tend to have more false inappropriate shock. Even the women patient have more incidence of cardiac event during follow-up, but because of treatment of implantable cardiac ICD is very effective, so the long-term prognosis is similar between the female patient with short QT syndrome and male patient with short QT syndrome. And what about long QT syndrome? Yeah, I think Dr. Paramaran talked about much about long QT syndrome in the young. And the general idea information is that in the young patient population, the men or the male patient tended to present at the younger age. We can look at this figure. So before puberty, we can see more male patients with long QT syndrome presented with sudden cardiac death. And after puberty, we see more female patients with long QT syndrome. We can also see this slide when we look at the age at initial presentation or the first cardiac event. When in the younger population, we see more male patients with long QT syndrome. And after age of 20, we see more patients with female patients with long QT syndrome. Yeah, we can see more and more female patients with long QT syndrome when the age get older. But through because the patient with long QT syndrome, the incidence rate is not very high in the Asia Pacific region. I reviewed the rate of sudden cardiac death for patients with long QT syndrome in the Asia Pacific region. In general, there is no difference of rate of sudden cardiac death or cardiac event in male patient or female patient with long QT syndrome. So, but when the age of the patient is older than puberty, between 15 years old and or even more 40 years old, we can see more female patients presented with sudden cardiac death. So this is the same information as I told. So finally, we look at Brugada syndrome. I think this is very well known to all the cardiologists in the Asia Pacific region. The male patient is more likely to present with type 1 ECG and aborted sudden cardiac death. And the prognosis for the male patient with Brugada syndrome is much worse than female patient with Brugada syndrome. Yeah, I think this is very well known to all the cardiologists in the Asia Pacific region. So finally, we look at some rare conditions that are associated with sudden cardiac death in adult patients. We first look at the bicuspid aortic valve. In those patients with bicuspid aortic valve, the female patient is more likely to have severe aortic stenosis. So the incidence of cardiac event for patients with bicuspid aortic valve is higher in the female adult patient. And for degenerative aortic stenosis, especially for those patients with low cardiac output, severe aortic stenosis, we can first look at these two lines and these two lines for all those patients that receive intervention, either surgical intervention or TAVR. The prognosis is better in the intervention group than the non-intervention group or medical treatment group. But the female patient tended to have less response to any treatment or intervention. Or in patients with degenerative aortic stenosis and that decreased left ejection fraction, the female patient have a worse outcome, even they receive intervention, either surgical intervention or percutaneous intervention. And what about the Marfan syndrome? The male patient with Marfan syndrome is more likely to have aortic root dilatation, and more male patients receive prophylactic aortic surgery that indicate that the incidence of sudden cardiac death for Marfan syndrome is higher in male adult patient than in female adult patient. So now I want to conclude my talk. The number one cause of sudden cardiac death in the adult population is ischemic heart disease. And because the man is itself, the female gender itself is associated with a higher risk of ischemic heart disease, so men in generally have a higher incidence of sudden cardiac death than women. But the prognosis of men may be better if the patient presented with acute myocardial infarction or acute coronary syndrome. And for the cardiomyopathy, we can discuss about hypertrophic cardiomyopathy. In my review, the female patient is more likely to have outflow tract obstruction and the higher incidence of sudden cardiac death. And for dilated cardiomyopathy and arrhythmogenic RV dysplasia, the prevalence and the prevalence is higher in male patient. The male patient also have severe symptoms and also worse outcome. And for those with tachytubal cardiomyopathy, female patient are more frequent, and the prognosis is also worse in the female patient. For long QT syndrome, the men present more often with syncope. The women population have a higher incidence of cardiac event during follow-up. And for long QT syndrome, the men tend to present at a younger age. And at the older age, for example, after puberty, more female patients with long QT are seen. For Brugada syndrome, it's very simple. Men have a higher incidence of sudden cardiac death, higher incidence and prevalence of Brugada syndrome in the male population. For the patient with congenital aortic valve disease, for example, bicuspid aortic valve disease, the woman population is more likely to have severe aortic stenosis and higher incidence of sudden cardiac death. But in the Marfan syndrome, the men are more likely to have pathology, severe pathology in the aorta and the higher incidence of sudden cardiac death. Thank you for your attention.
Yes.
Any question for my talk?
Why the first attack of sudden cardiac death is in younger age in males?
The initial presentation, the male patient tended to, the first diagnosis of hypertrophic cardiomyopathy is also younger in men, like the patient with long QT syndrome. But the long-term prognosis maybe is better in the male population.
or it may be more worse ischemic heart disease in males, which is responsible for the male patients during a younger age, or this first attack.
Yeah, as I thought, the male gender itself is a risk factor of ischemic heart disease. So in general, the prevalence and the incidence of ischemic heart disease is higher in the adult male population. But this is also my first time to know that the prognosis after first myocardial infarction or acute coronary syndrome is better in the male population, especially in our country. Yeah. But the prevalence is higher, or ischemic heart disease is higher in the male population. Yeah. But the prognosis may be better. Yeah.
What is the evaluation rate of these patients in your country?
I'm sorry, can you repeat the question again?
What is the evaluation rate? Have you any state insurance support in your country?
Yeah, the health insurance for my country for the treatment of all the cardiovascular disease is almost 100% covered. Yes.
So evaluation is a pretty costly procedure.
Very weird.
In low-income countries, of Asia Pacific, usually patients cannot go for the extensive evaluations in these cases.
So
Thank
there
you.
must be other reasons to explain the higher mortality in the female patient after myocardial infarction, because in our country, the treatment coverage and the treatment modality is exactly the same between the male patient and the female patient. So there must be some unknown reason, yeah, that have explained the higher mortality or worse survival in female patient after myocardial infarction or acute coronary syndrome in Taiwan, also in other regions. Yeah. Because the treatment, in my experience, is very similar between men and women. Yeah.
It has been a very excellent talk. Thank you so much, Doctor. And we will move to another speaker now. Dr. Yang-Ming from the National Cardiovascular Center of the Third State Central Hospital of Mongolia.
Okay, thank you.
I
Just for a
request
moment.
our next speaker to present her topic.
Okay, just for a moment. I'm gonna share the slides. So okay, can you hear me?
Yes.
Yes, thank you for the chairman. Dear speakers and colleagues joining us here today, good afternoon. I would like to thank Asian Pacific Society of Cardiology for this opportunity to share this interesting subject about sex differences in prevention and treatment of heart failure with preserved ejection fraction. So heart failure with preserved ejection fraction is very common these days. Community-based cohort studies suggest that HFpEF accounts for 40 to 50% of overall heart failure incidents, and its prevalence is rising over the time. Also, both HFrEF and HFpEF is associated with high morbidity and mortality. As for HFpEF, after hospitalization, the 5-year survival is only 35. Majority of the studies show that HFpEF is more prevalent in women. So even though we don't have enough management evidence about HFpEF, so but a better understanding of potential sex-specific mechanism in HFpEF may provide important insights for the future prevention and management. In Swedish Heart Failure Register, which enrolled over 40,000 patients, sex was differently distributed across the heart failure phenotypes, with more females in HFpEF, accounting almost 55% of the whole HFpEF population. But male patients were more prevalent in both mid-range and reduced ejection fraction phenotype. So we will mainly discuss about the woman in this subject. Sorry, we will discuss about, I'm sorry. So same registry data shows compared with males, female were much more older, and majority of them were hospitalized, had longer duration of heart failure, and more likely to have higher NYHA functional class, which means they are much more sicker. So again, compared with men, women were more obese and more likely to have a history of hypertension, chronic kidney disease, and less likely to have history of ischemic heart disease. Whereas most common comorbidities in men was coronary artery disease. In recent data meta-analysis of the largest HFpEF trials, including charm-preserved, eye-preserved, and TopGet trials, showed that women had more symptoms of heart failure than men, and they had poorer health-related quality of life. And women also had a significant higher percentage of ejection fraction and lower median NT-proBNP level comparing with men. Also, this meta-analysis results showed female had better prognosis, whereas women had lower risk of cardiovascular death. And most striking difference was the risk of sudden death occurred almost twice as frequently in men as in women. So in exact pathophysiology of the HFpEF is still unknown. This article, which was published back in 2018 from Anne Bill colleague, had detailed explanation of possible mechanisms of HFpEF in women. From many different aspects, these women were in women, there were several fundamental differences that lead to the higher risk to develop HFpEF. So these differences includes sex differentiated gene expression, smaller anthropometry, sex-related hormone, for example, estrogen level, and higher inflammation response, and cluster of the risk factors and comorbidities. So these, all these differences could influence cardiac structure, cardiac metabolism level, as well as the vascular function. For example, from the cardiac structure point of view, woman has smaller chambers, which leads lower stroke volume, and woman has lower diastolic compliance, which worsen with age, also has higher occurrence of LV thickness and concentric remodeling. There are common risk factors and comorbidities associated with HFpEF in women. Risk factors like old age comorbidities, including hypertension, obesity, diabetes, iron deficiency, anemia, and autoimmune disease, could contribute to HFpEF risk in women. Also, there is unique risk factors for women in HFpEF, including pregnancy complications such as preeclampsia and multiparity. Study shows that women with history of preeclampsia have a four-fold higher incidence of essential hypertension and at twice the risk of coronary artery disease and stroke, and are nearly 80% more likely to develop heart failure than women without hypertension during pregnancy. On the other hand, invasive exercise study shows women who had 3 or more births had higher exercise-induced pulmonary capillary wedge pressure, greater rise in right atrial pressure with exercise, which means multiple births could associated with greater LV stiffness, pulmonary vascular dysfunction, which can lead to HFpEF. So let's talk about prevention. So from epidemiological and pathophysiological differences in HFpEF strongly suggest that sex-specific preventive strategies is needed, but unfortunately, up till now, we don't have enough evidence about prevention of HFpEF in women. But since the prevalence of female HFpEF is higher, we will more concentrate in women heart failure prevention. Again, there is no sex-related specific guidance for primary prevention. However, it's recommended that adapting general prevention activities, such as maintaining a healthy body weight, weight loss, for obese people, smoking cessation, glucose control for diabetic patients, and regular exercise is still advised. Especially treating hypertension and maintaining healthy weight is maybe most important for women, lowering incidence of HFpEF. And about statins, it's one of the few drugs such as actually could have a beneficial effect on HFpEF patients for primary prevention. So we will discuss it later. So numerous risk factors contribute to the development of the heart failure, but the prevalence and attributable risk is different between men and women. So compared with men, women with HFpEF are typically obese and have greater prevalence of hypertension, and both obesity and hypertension can be controlled as a primary prevention from HFpEF. As for hypertension, treatment and follow-up should be done following existing international guideline, but unfortunately, there is no sex-specific information. Because of the inflammation and insulin resistance associated with obesity is believed to be strongly associated with HFpEF, weight loss could be very important and effective method for preventing HFpEF in women. About obesity, there was a newly published study about sex-specific differences in visceral adipose tissue relation in HFpEF. So visceral adipose tissue is a fat that's stored around internal organs, usually more prevalent in men, but has a potential role for increased risk of cardiometabolic syndrome. So in this study, results showed that compared with control women, vascular adipose tissue area was 34% higher in women with HFpEF, while this adipose tissue area was not significantly different in men with or without HFpEF. So in this study also described that exercise-induced elevation of pulmonary capillary wedge pressure was also seen in excess visceral adipose tissue women, but not in men, which means women display multiple differences in body distribution of fat that may be relevant to the development of HFpEF. In order to, so on the other hand, weight loss is very important for women in prevention. About exercise prevention, recently a study which was enrolled postmenopausal women without heart failure found that healthy lifestyle pattern reduces risk of HFpEF. In this study, enrolled almost 40,000 menopausal women without heart failure and followed over 14 years. So, and calculated lifestyle factors for this woman associated with developing HFpEF. So in this study examined for different types of lifestyle variables, including diet, physical activity, smoking status, and BMI. So each woman received 1 point for every health variable. Points were summed, as we can see from this table, that having just one healthy lifestyle associated with higher risk of heart failure with an adjusted hazard ratio of 0.47 compared with having no healthy lifestyle factors. So there is whereas a heart failure risk factor was lowest in participant with all four healthy lifestyle factors. So in other way, it means for women, especially in postmenopausal period, a healthy lifestyle intervention is very important for prevention. It could lower heart failure risk, especially HFpEF. About statins, the positive effect on statin use in patients with ischemic heart disease is well documented. We all know that. The exact mechanism of the potential statin benefit in HFpEF function is still unknown, but during HFpEF, there is a pro-inflammatory state. So, and mechanisms behind HFpEF is maybe usually could be related to comorbidities and systemic and microvascular inflammation induced by these comorbidities. So having multiple effect of statin can be beneficial for prevention of HFpEF. So there have been studies demonstrated that statin could reduce death and heart failure related hospitalization. Also, some studies demonstrated that it has atrial fibrillation prevalence or lower in statin when statin was used. So this is that study. Actually, atrial fibrillation is an independent risk factor for development of HFpEF. So newly onset HFpEF patient study shows that conventional risk factors reveal that atrial fibrillation is a risk marker for the development of HFpEF in women. So that's why statin possibly can be used for primary intervention in women with HFpEF. However, well-powered studies still needed to be done for better evidence. So let's move on to the treatment. I will talk about the pharmacological and non-pharmacological treatment as well. Till now, there is no definite evidence of pharmacological therapies that have shown efficacy to HFpEF. So current ESC, heart failure management guideline, recommends to screen patients for possible comorbidities and treat those comorbidities in order to improve well-being and prognosis. So in the 2016 guideline, only recommended pharmacological treatment is diuretics in order to control volume, status, and relief syndrome. As well as in the American Heart Failure Guideline, also recommended to treat underlying comorbidities and additional to use diuretics for symptom relief. So several large clinical trials showed that pharmacological interventions can reduce the mortality and morbidity associated with HFrEF, but many effective treatments for HFrEF unfortunately have shown disappointing results when applied to HFpEF patients. And also less than 10% of recent randomized controlled trials report reaction of the drug for women and men separately. So this table summarizes measured trials for HFpEF. Also some other agents, including digoxin, sildenafil nitrates, and all of these didn't have any beneficial effects for HFpEF. A trial that had sex-specific subgroup analyses were highlighted in blue, that includes TOPCAT and Paragon heart failure. So about TOPCAT trials, post-COP analysis showed that there was efficacy of spironolactone to reduction of heart failure hospitalization in Americas. So in 2017, American heart failure guideline also included new class 2B recommendation for using spironolactone in selected patients, particularly those with elevated natriuretic peptide levels with close monitoring of potassium level and renal function. Also, in subgroup analysis of TOPCAT trials showed that spironolactone has a beneficial effect on women. There was a reduction of all-cause mortality, but did not in men. So spironolactone therapy could be more effective for female than male patients in HFpEF. About Paragon heart failure, unfortunately, sacubitril/valsartan combination did not have statistical significance in primary endpoint, but pre-specified subgroup analysis showed that sex and ejection fraction appeared to be modify the treatment with a more favorable effect in women than in men. That's why researchers furthermore detailed investigated association between sex and effect of treatment. In that sub-analysis, there were several differences in baseline characteristics between men and women, which was women were much more older, they were much more obese, and they had more kidney dysfunction and lower NT-proBNP level than men. So also women were more symptomatic. So from this figure, you can see that as compared with valsartan, sacubitril/valsartan combination in women seemed to reduce heart failure hospitalization more than men. Exercise intolerance is in primary manifestation for chronic HFpEF. So as for non-pharmacological treatment of HFpEF, I will introduce about exercise training and dietary modification. So exercise training has been shown to improve exercise intolerance. There were several randomized controlled trials were done and had very promising results, but unfortunately they were very small trials. For example, Chieh and their colleague has published study about caloric restriction and exercise training effect on HFpEF patient. And that study, majority of the patients, almost 80% of them were female. So after 20 weeks of exercise and diet, both interventions were associated with significant improvement in peak oxygen consumption and NYHA functional class. So we can see that there is a beneficial effect from dietary modification and exercise training in HFpEF in female patients. Also about novel drugs, SGLT2 inhibitors, we currently did not have evidence of use. Several large trials of SGLT2 inhibitors are on the way. Including Imperial, Preserved, Deliver, and Determined Preserved. They are all anticipated to be completed this year. So we hope for this trial to be succeed because we don't have enough evidence-based treatment for HFpEF yet. So in summary, HFpEF heart failure with preserved ejection fraction is most common subtype of heart failure in women with higher prevalence than in men. There are specific sex-related differences in terms of the risk and comorbidities. About management, certain non-pharmacologic and pharmacologic interventions may provide benefit in women with HFpEF based on limited data. So further investigation is needed to be better understand the mechanism of these interventions. Thank you.
Thank you, Dr. Yang-Ming, for excellent presentation. Can you impact on the life expectancy in have failure? And what is the life expectancy in these
life
patients?
expectancy in those patients? Well, actually, from the studies, HFpEF patients are much more older, especially the female patients. Especially female patients. So life expectancy is compared with the HFrEF, it could be much more longer because they are older people. But the incidence of the mortality rate, it's almost 35%, which means it's also high. Mm.
Can it be reverted as stress-induced cardiomyopathy and pregnancy-induced cardiomyopathies? And my third question will be, in what dose of the statins we can get benefit in this type of failure?
Excuse me, I think there is a connection loss. Can you repeat the question?
Okay. Can it be reverted? Can it be reverted like stress-induced cardiomyopathy and pregnancy-induced cardiomyopathy?
You mean they have PEF, right?
Reverted.
So
Yes.
still, I think we still not sure about it because the majority of the patients were older and they have a much more stiffer hypertrophied left ventricle. So whether is it can be reversed like some other like PPCM or not, we still don't know because those like LV ventricular changes like stiffness and hypertrophy is also follows the aging. So in this population, whether it modifiable or not, we still don't know because we don't have evidence-based good drug for this moment, I think.
What dose of statin will be suitable to improve the endothelial redox balance? And we can get desired results for the
So how to improve in
dose
pathology?
of the statin therapy to revert to get desired results in this type of heart failure.
So about therapy, we still don't have enough evidence, but we just only one drug that recommended is diuretic. So other drug, what special doses, how can we use that? We still, I think we still unclear about it. Yeah.
There's still no consensus on the dose of statin in this condition.
About the dosage of the statin. Actually, there were several studies, but I think the dosage is this average. They all said is a standard dose for statin.
Thank you, Dr. Chen, for excellent presentation. We are now moving towards the next Dr. Jar Sisan, please.
Thank you very much, Professor Soomro. Thank you. Thank you, APSC and Dr. Dean for the invitation. Being the last speaker, I'll try to make my presentation very brief. So if I may share my slide, can you allow me to share my slide, please? May I request you to allow me to share my slide? Okay. Okay, that the topic assigned to me today is about the sex difference in the prevention and treatment of heart failure with a HFrEF. And this is the lecture outline of my talk. I will talk about briefly the epidemiology and then the review on the pathophysiology of heart failure. And then we'll focus on the gender or sex differences in the risk profile. And then I'm going to run through the different HFrEF trial and their outcomes. And so I first go to the epidemiology. Heart failure, as we know, affects more than 60 million people worldwide, and the prevalence is expected to increase because of the aging population. And then the lifetime risk of heart failure is about 33% for males at age 55 and 28.5% for women. Heart failure has a high mortality rate of 40% within 5 years after discharge from the hospital. And there's even higher hospitalization rate after this or recurrence of heart failure. While mortality from major cardiovascular disease is declining, there has been an increasing or there is no decline in the incidence of mortality from heart failure. This is data from the National Health, Nutrition, Examination Survey from 2009 to 2012. As you can see, the males were predominant in the prevalence of hypertension, of heart failure, up to the age 60 to 70. But at the age of 80 and above, there is a predominance now of the female population afflicted with heart failure. As we know, if I may reiterate, heart failure poses a very significant burden for everyone. More than 60 million are affected. And then approximately 50% of these patients diagnosed with heart failure will die within 5 years. And the most important driver for the burden from heart failure is hospitalization. As we know very well, the frequency of hospitalization is high after diagnosis of heart failure, and it's the #1 cause of hospitalization in patients above 65 years of age. And then after discharge, the readmission rates for heart failure is as high as 30% within 60 to 90 days. And approximately 30% of these patients will die within 1 year. So that is how morbid heart failure is. Now let's run through the pathophysiology of heart failure. We know very well that heart failure is not a single disease, but it is a syndrome associated with multiple risk factors and comorbidities such as diabetes, hypertension, CKD, obesity, etc. And there are two main pathways of heart failure. On the first part will be the systemic pro-inflammatory phase or disease state that will lead to microvascular endothelial inflammation. And this will lead to the stiffness of the cardiomyocyte that will lead to fibrosis and eventually causing HFpEF, as was described a while ago by our previous speaker. Also, this cardiomyocyte stiffness will contribute to LV hypertrophy. It can be protective, but it can also be maladaptive. On the other hand, because of the comorbidities of the heart failure, there will be myocardial or cardiac injury that will lead to oxidative stress in cardiomyocytes. And this will lead to necrosis, apoptosis, and that will lead to HFrEF or reduced ejection fraction type of heart failure because of a reduction in contractility. And it will also contribute to LV hypertrophy. And very important in heart failure syndrome is the quality of life that is very much affected and leads to greater risk of rehospitalization as well. No? As you can see here, as the symptoms of heart failure progresses and deterioration happens, there will be a deterioration also in the quality of life. And this happens as we progress in the severity of heart failure from class 1 to class 4 of the New York Heart Association. Likewise, the correlation of quality of life is very direct with rehospitalization within 1 year. So as you can see, as the quality of life deteriorates, there is an increasing rate of hospitalization for heart failure within 1 year. This is just a story of what happens in acute heart failure and subsequent events. Now, as you can see, during the first or acute event, there will be deterioration of the myocardial function, and the patient is hospitalized. After treatment, there will be improvement in the myocardial function. The patient is discharged, and then after a certain period of time, there will be another trigger that will cause an acute decompensation of heart failure again, and the patient will be rehospitalized. And after treatment, there will be improvement again, and so on down the line. But as you can see, as this trend progresses, there will be a downtrend of the myocardial function until there will be a severe decline in the myocardial function and death. So this is really the morbid event and the morbid situation that happens in heart failure. There are two main categories of heart failure, as I explained a while ago. The first one is the FREF, or the reduced ejection fraction type, where the EF is less than 40%. And as I've shown you, that is due to the loss of myocardial systolic function, and it accounts for half of the cases of heart failure. No? And of the causes are the myocardial injury, like remodeling, dilatation, because of the heart attack that happened, okay? And this is the main population that are involved in large trials, and that's why in the HFrEF trials, we have a lot of evidence to show that there is residual risk for morbidity and mortality despite current treatment. While the HFpEF has been elucidated by a previous speaker, and up to this time, there's no proven treatment that will improve the morbidity or the outcome of HFpEF. So if we are to compare the prognosis of both types of heart failure, they are very much similar in terms of mortality within 5 years. You see, they have both 75% risk of mortality, and the readmission is also almost similar at 82.2% for HFrEF and 84% for HFpEF. And mortality and readmission is also very high. It's very similar for both HFrEF and HFpEF. Now we come to the gender differences and also the risk profile. And this was shown to us in the previous lecture, that both the female and male population in the InterHeart study shared the same risk factors that leading to heart attack or myocardial infarction, no? Smoking, diabetes, hypertension, obesity, and mind you, these are the same risk factors that contribute to the development or progression of heart failure. And the risk factors associated with heart failure and its underlying pathophysiology may differ by gender. It has been shown in the study by Pedrotti that women with heart failure have more hypertension, more valvular heart disease, more thyroid disorders than men, but they are less likely to have obstructive coronary artery disease. But even if they have less obstructive coronary artery disease, when it is present in women, it becomes a stronger risk factor for the development of heart failure than men and than hypertension. The risk factors, as we know, that are selective for women would include cardiac toxicity from chemotherapy as treatment for breast cancer, and also peripartum cardiomyopathy. And women who present with acute decompensated heart failure are twice likely as men to develop HFpEF, and this is the peculiarity of women. More women have more HFpEF than HFrEF compared to men. The profile of heart failure and its underlying pathophysiology also differ in terms of the echocardiographic parameters and LV function. In women with an impaired LV ejection fraction, they will still have a relatively higher ejection fraction than compared with men. Women with the heart failure have lower quality of life, they have lower functional capacity, they have more hospitalization for heart failure, and more frequent episodes of depression. But nonetheless, the overall survival rate of women is relatively better as compared with men with heart failure. How about the diagnosis of heart failure? In terms of diagnosing acute heart failure, based on the studies of left ventricular dysfunction or SOLVE study, it showed that women with impaired systolic ejection fraction were more likely to have edema, were more likely to have elevated jugular venous pulsation, and also S3 gallop than men. Women also have inherently higher baseline BNP values compared to men. But if their BNP values are higher than 500 pg per ml, it is more predictive of mortality and strongly in women than in men with heart failure. Regarding the treatment of heart failure, whether men or women, they all benefit from the treatment of heart failure. Since the women population are underrepresented in many or almost all heart failure trials, and the fact that HFpEF is more prevalent in women, then we lack enough evidence regarding the treatment of heart failure in women. Evidence-based heart failure therapies, including ICDs, are also underused for both sexes, but also more underused in women. Women are less likely to receive vasoactive agents or inotropics, but men and women have equal hospital length of stay and also age-adjusted in-hospital mortality of heart failure. This is just to show you in a nutshell the foundational therapies for heart failure use, particularly the reduced ejection fraction type of heart failure. We have already included in the foundation therapy the sacubitril valsartan molecule or treatment called ARNI. We also include in the foundation therapy the ACE and the ARB or the RAS blockers. We also include MRA antagonists, the beta blockers, and very recently there will be an inclusion, if approved by the several FDAs and societies, the SGLT2 inhibitor might be also part of the foundational therapy in HFrEF to reduce mortality. Now we go to the HFrEF trial outcomes that have recently came out, and one of the first treatment will be the PROVE-HF sub-analysis. If you may recall, PROVE-HF was done using the RNA sacubitril valsartan using biomarkers for health, status, remodeling, as well as cardiac function. But this hub analysis involved sex-based differences in these parameters, biomarkers, health status, and remodeling. The aims of the PROVE-HF was to determine the sex-based differences in biomarkers, self-reported health status, magnitude of longitudinal changes for cardiac remodeling, in heart failure, ref, and also using the ejection fraction, all treated with sacubitril and valsartan. This is a 52-week multi-center open-label single-arm study enrolling almost 800 patients with chronic HFrEF with sacubitril valsartan. And the dose was up-titrated to target 200 milligrams twice a day. And the parameters used in this study were the plasma proBNP, the echo LVEF, LV mass, LV volume, diastolic function, and these were monitored from baseline, 6 months, and 12 months. The cardiac reverse remodeling was defined by the changes in the ejection fraction, the LVEDV index, and the LVESD index. And the health status was based on the Kansas City Cardiomyopathy Questionnaire for Quality of Life Assessment. So this is the result of the PROVE-HF analysis or sub-analysis. As you can see, men had a greater decrease in NT-proBNP during the first 3 months of the observation than women. However, across the 12 months of follow-up, women tend to have more consistent reduction in proBNP. With regards to the parameters of cardiac function, women and men demonstrated very comparable reverse cardiac remodeling based on the ejection fraction. As you can see here, very comparable improvement in ejection fraction. And also, but notably, women tended to reverse remodel early during the first 6 months. As you can see here, the LVEDV, as well as the reduction in LVESB for the first 6 months among women. But conversely, during the last 6 to 12 months, men tend to have larger reduction in the parameters of LV dysfunction. With regards to the quality of life, women tend to have an earlier benefit or improvement in quality of life for the first 3 months based on the KCCQ questionnaires. And this was a lot better than what they saw in the men population. Now let's go to the hard endpoints of the HFrEF trials. First, we have been introduced to the Emperor reduce that was presented last year, wherein empagliflozin was used in this study versus placebo. This was the design of the study. It's a phase 3 randomized double-blind placebo-controlled trial aimed to look at the composite endpoints of time to first adjudicated death, cardiovascular death, and heart failure. And then the secondary endpoints are first and recurrent adjudicated heart failure events, and also the other endpoints, renal function. This was 16 months of the average of event-driven study. And as you can see, we were excited to see a 25% relative risk reduction with empagliflozin as versus placebo on the reduction of primary endpoint during the 16-month observation. if we look at the sub-analysis of this primary endpoint outcome of the emperor, comparing the male and the female, as you can see, they have equal benefit with this treatment for both male and female. Now we go to the other landmark trial, the paradigm heart failure trial, wherein angiotensin receptor neprilysin inhibition treatment was compared with an ACE inhibitor, enalapril. Of course, we know very well that this treatment involved more than 8,000 patients with HFrEF, less than 40% ejection fraction for class 3, class 2, class 3, class 4 heart failure. And the above study compared ARNI versus the enalapril or ACE inhibitor, 10 milligram BID and 200 milligram BID for the ARNI. And this was the result of the paradigm HF. The primary endpoint of the composite cardiovascular death of heart failure hospitalization was 20% lower with the LCZ 696 or the ARNI, and the p-value was very, very significant. So 20% reduction in the primary endpoint. How about the cardiovascular death? As you can see, we again saw a 20% reduction with the ARNI treatment as compared with the ACE inhibitor and enalapril. How about the all-cause mortality? There was a 16% significant reduction in all-cause mortality with the ARNI as compared with enalapril as ACE inhibitor. Now, regarding the analysis of this paradigm HF trial, they have identified that the levels of neprilysin had no relationship with female or male, age, body mass index, renal function, as well as the NT-proBNP levels. And in real-world population with HFrEF, there was no significant sex difference observed in treatment response to ARNI or sacubitril valsartan. When they tried to pull the analysis of Paragon HF and the Paradigm HF trials, the effect on modification of ejection fraction on the efficacy of sacubitril valsartan or the ARNI was similar for both men and women. There was more benefit from the ARNI treatment at lower ejection fraction for both men and women. But the upper threshold of loss of benefit was higher, almost 60% in women. That means to say that women have a better threshold than men, who is only seen in 45 to 50%. Now let's go to the other landmark trial for HFrEF, another SGLT2 inhibitor, the DAPA-HF in patients with heart failure and reduced ejection fraction. Included in this treatment or trial were adult males with heart failure HFrEF of at least 2 months and ejection fraction of less than 40% within the past 12 months. And they are already on optimal heart failure treatment. As I mentioned earlier, the foundation therapy, the ACE inhibitor, the ARB, and then of course the ARNI, beta blocker, MRA, and some have device therapy. And in a capsule, these are the results of the DAPA heart failure trial. With regards to the primary outcome, there was a 26% reduction in the primary outcomes of cardiovascular causes of hospitalization, mortality with dapagliflozin, hospitalization from heart failure. Again, there was a 30% reduction with dapagliflozin as compared with placebo. With regards to the death from cardiovascular causes, there was an 80% lower outcome with dapagliflozin as compared to placebo. And finally, death from any cause, there was a 17% reduction in dapagliflozin. Looking at the sub-analysis of the DAPA-HF and trying to see if there is any difference in the gender effect, as you can see, similar to the emperor reduced trial, both male and female population benefited, but the males showed to be much more significant, but both genders geared towards a favorable effect of dapagliflozin. So my colleagues, ladies and gentlemen, let me summarize that heart failure affects more than 60 million people worldwide, and the prevalence continued to increase because of the aging population, especially in the first world countries. The mortality in heart failure remains high in contrast to the declining mortality in the major cardiovascular diseases. The heart failure is a disease associated with multiple risk factors and comorbidities. The heart failure reduced ejection fraction or HFrEF accounts for 50% of HFrEF. On the other hand, HFpEF also accounts for 50% of heart failure cases. I have shown you that there are gender differences with risk factors, with underlying pathophysiologic mechanisms of heart failure in men compared with women. However, as I have shown you, the large trials on HFrEF outcomes showed very similar benefit or very similar effects for both male and female. With that, I'd like to thank you for your attention.
Thank you.
Thank you.
Can you hear me?
Yes, I can hear you, Professor.
Okay. So thank you so much for excellent lecture, and it was cleared many misunderstanding about this disorders of heart failure. So as well as you solved the problem of reversal of the failure as well. I would like to ask again the dose of statin in this condition.
Professor, can you again repeat your question?
I would like to ask about the dose of statin in this condition. As the previous speaker asked, yeah.
Well, very similar to the previous heart failure therapy statin, we can use the moderate and with high intensity statins that we use according to the guidelines we see in the AHA and ACC. We can do 40 milligrams of up to 40 milligrams of rosuvastatin and then 80 milligrams maximum of atorvastatin for the high intensity. And then for the moderate intensity, we can do lower than that. And then we can use the other statins like pravastatin, pitavastatin, and the others.
Dr. Lin, will you wind here?
I think, yeah, it's very interesting to listen to the difference in reduced EF and preserved EF heart failure. it seems to me reduced EF actually is more related to ischemic heart, and but many of them actually redilated. I just wondering why a male have more reduced EF heart failure. It seems to me the preserved EF is just like Dr. Ganji said, it seems it's more related to diabetes or more diffuse atherosclerosis, the kind of non-STEMI, maybe more in female. But I just don't know why male should be suffering more from reduced EF heart failure. It seems much less survivor. I would say, George, how do you feel about that? Why
Well, I can
we are
start back.
so bad up?
Thank you, Professor Lin. That's a very good question. Everybody knows that male are just being a male is a risk factor. You are a risk factor, me a risk factor. But kidding aside, comparing to female, before menopause of female, the male species start to generate more risk factors, right? As you can see in my presentation, the smoking prevalence is very much higher, almost 8-fold in male than female. And then, of course, the hypertension, and then stress relation, the alcohol abuse, and all of these risk factors are more prevalent with the male population before the menopausal age of women. But after 65 and so forth, women will catch up. But they catch up late. That's why they are still with HFpEF, as explained by Dr. Yang-Ming. So that's as far as my opinion on why men are more have HFrEF.
How about the Ganjiman? How do you feel? Is it why female has more HFpEF?
Well, as explained earlier, actually, HFpEF is more prevalent in postmenopausal period. So when we are older, we have much more risk to having an incident of HFpEF. I guess it's this is the reason.
Because one of the mechanisms is saying that it's because of inflammation that causes the HFpEF. Inflammation and cause the NO production reduction that cause more microvascular problem, more HFpEF. But in male, actually, it's more coronary risk factor that cause the infarction or ischemic damage and cause more HFrEF. And how do you feel? What is the difference of the information so different between male and female?
Well, I think there is some studies have been suggested that actually this estrogen role and others suggested that females who have had HFpEF is actually very obese people. So in obese people, the adipose tissue also associated with the inflammation. So it could be explained in different way.
Yes.
No more question for me. Maybe Professor Soomro, you want to have the closing conclusion for us?
No, you can, because you are host, so it will be from your side. Dr. Lin, you are host, so it should be from your side.
Pardon me? Oh, Parabon? Yes.
You are host of the event and excellent organizer. This should be your privilege to conclude this session. Can you hear me?
Can you repeat the question for us?
No. I wanted to say that you are excellent organizer. I know this the whole event was your effort, so it will be your privilege to conclude.
Thank you. It really takes some time to have everyone together. I really appreciate that everyone can contribute to this quite extended version of the webinar, and quite a difficult one actually. So it's not easy to invite everyone here, and it's really very helpful for myself that I learned a lot from the silent cardiac test in the young and also in adults, and also heart failure in reduce and preserve EF, and also in the prevention of coronary heart disease, the atherosclerotic heart disease in male and female. I really learned a lot. I think everyone must have learned a lot because we know more specifically and deeply enough to know about the difference between male and female. So what I know mostly is that I know that men can die earlier for many reasons compared to female. How do you think that, George? Do you think we will live longer or maybe?
We're trying our best, but I know the women live longer.
well, maybe Dr. Badarapong, how do you feel? It seems that male also suffer more some kind of death, even without.
There is some explanation in South Asian countries, developing countries. Women are more working. I mean, physical work they usually do. So that may be the reason for their long life and healthy life. Exercise capacities.
Okay. Yeah. Oh, well, thank you everybody for joining this extended webinar. Thank you. And we will close.
Goodbye.
Bye.
Goodbye.
Thank you.
Everybody stay safe.
Bye-bye.
Bye-bye.
Thank you. Thank you, Dr. Soomro. Okay. Thank you. Bye-bye.